All right, so heart failure is the inability of the heart to pump sufficient blood to meet the needs of the tissues for oxygen and nutrients. So we talk about systolic heart failure and diastolic heart failure. So systolic failure is the inability of the heart to pump effectively due to impaired ventricular contraction. Diastolic failure is the inability of the heart to pump due to impaired ventricular relaxation. So with systolic, your issue is that ventricular contraction, and diastolic is that issue with it not being able to properly relax, which then causes an issue with filling. So when we think of our heart, we want to think of our heart as kind of like a double pump. So the right side of the heart is going to pump that deoxygenated blood to the lungs for oxygenation. The left side is going to pump that oxygen-rich blood into the systemic circulation and perfuse all of our organs. Our heart is responsible for providing a continuous supply of oxygen and nutrients that we need for cellular metabolism and a mechanism to get rid of all that carbon dioxide that builds up in any kind of metabolic waste. And any type of disturbance in one part of the heart is eventually going to affect the entire circulation. All right, and so when we talk about heart failure, the way that we can gauge heart failure is that we can do an echo on our patients and we can look at what we call their ejection fraction. So the ejection fraction is the percentage of blood that the left ventricle ejects every time it contracts. In a normal functioning heart, we want that to be 55% or more. So 55% or more of the blood that fills the left ventricle during diastole. That's indicative of a healthy, normal operating heart. Any number less than 55%, then we obviously know there's some type of heart issue. It is indicative of heart failure. So as the heart continues to fail, the amount of ejected blood is going to decrease. You measure it with an echocardiogram. And when we talk about the term congestive heart failure, that describes the accumulation of blood and fluid in our organs and tissues because we get that impaired circulation because that heart isn't squeezing properly and it's not ejecting enough blood to circulate through the body and perfuse all the organs. So we can classify heart failure by acute and chronic. So acute obviously is a sudden change in the heart's ability to contract. So it just happens all of a sudden. And it can cause life-threatening pulmonary edema. Chronic heart failure is when our heart's ability to pump is gradually compromised. So it doesn't happen overnight. It happens over a period of time, weeks, months, maybe even years. And the inability to contract properly is going to be prolonged. So here's a nice little chart that I pulled from your book. So anything greater than 55% when we measure that ejection fraction, again, is normal. Anything between 45 and 55 is considered mildly reduced. 35 to 45% is moderately reduced. And then less than 35 is going to be severely reduced. So we can have left-sided heart failure and right-sided heart failure. So you guys need to know the difference between left-sided and right-sided. You need to know what is causing each side to fail, where the problem is, and you need to know the signs and symptoms as we're talking about this. You're going to see this on your exam. So left-sided heart failure is the inability of that left ventricle to pump effectively. It leads to a backup of blood in the pulmonary circulation and decreased oxygenation. Left side of the heart is being unable to pump enough blood out into the body to oxygenate the tissues, backing up into the lungs. So it's the left side. We're trying to pump it out. We're not getting that good squeeze in the heart. It's not squeezing effectively enough to really force that blood through to continue with that good circulation. So instead, we're just getting these little ineffective squeezes and it can't get out. So it's just backing up and filling up and filling up. So if it fills up and it goes into your lungs, you know you're going to have oxygenation issues. Right-sided heart failure is the inability of the right ventricle to pump effectively, leading to a backup of blood in the systemic circulation. Blood is going to back up from the heart into the body, so it can't get through back to the right side of the heart. It's going to pull in our extremities. We're going to have blood clots, things like that. So you really need to understand where the issue is and what the issue is causing. So this is a little cartoon thing for you guys to look at, where I'm not going to read all of it, but this is going to give you signs and symptoms of what your patients would present with left-sided versus right-sided heart failure. So left-sided heart failure is going to come from conditions that impair that left ventricle. So that left ventricle, it's going to mess with the ability to be able to eject blood into the aorta. Right-sided heart failure is when the right ventricle fails to eject its diastolic phyllic volume into the pulmonary artery, causing congestion of blood in the venous vascular system. So when we see left or right-sided heart failure, the primary reasons are usually because the heart muscle cannot contract properly due to some type of damage. We might think of a myocardial infarction, where there's been ischemia to the heart, and a part of it is actually necrotic and it's died, so it's not going to be able to contract properly. Or it can be an issue with the pumping chambers, so they can enlarge and they can weaken. So this is what we talk about when we see patients that have cardiomyopathy and hypertension. So remember, we said with hypertension, the heart is always having to try and contract against a higher force, which means it's pumping harder, it's pumping faster. That muscle is working in overtime. Because it has to work so hard for such a long period of time, everything in the heart starts to enlarge. And then we see this heart failure. The major cause of right-sided heart failure is left-sided heart failure. And then chronic obstruction pulmonary disease, COPD, also contributes to the development of right-sided heart failure. Some other contributing factors that cause heart failure, we have coronary artery disease, cardiomyopathy, hypertension, and then we see it with heart disease that affects the valves. So just like other body parts, we have compensatory mechanisms in the heart that will step in to try and fix issues with the heart when it's not pumping effectively. So one of the first systems that we will see activated is the sympathetic nervous system. So when the body recognizes a low blood pressure because our heart is not pumping effectively, it's going to release epinephrine or norepinephrine, or both together. That's going to stimulate a rise in the heart rate, which is going to pump out more blood, and it's going to raise the blood pressure. This system fixes the blood pressure, but increases the myocardial oxygen demand. So we're going to pump out more blood, which is going to bring up that blood pressure, but we're still not going to get any more out with each squeeze. We're just going to be pumping it more. So we're going to get those ineffective outflow of blood, but we're just going to get it more often. And it's going to make more work for the heart. So the heart's going to work harder, and it's going to require more of an oxygen demand. Then we have activation of that renin-angiotensin-aldosterone system. I know you guys remember this from homeostasis. This is when the sympathetic nervous system is activated. It causes the body to shunt more blood to the brain and the heart, because those are the biggest organs, and the body thinks those are the most important to perfuse, and it takes it away from the kidneys and our liver. There's a sense in decreased blood flow from those kidneys, and it initiates that renin-angiotensin-aldosterone system. So then angiotensin is going to be released. Angiotensin is going to be released. It's going to increase that blood pressure. Aldosterone is going to kick in. It's going to cause that retention of sodium and water. So, remember back, whenever our body retains sodium, water is going to follow. So the sodium and the water are going to help increase that blood pressure. It's going to increase our volume. So then we're going to see that overall increase in our blood pressure. Then we have the release of the atrionatriuretic peptide, the ANP, and the B-type natriuretic peptide, the BNP. That's going to happen by the atria and the ventricles. So they will sense an increase in fluid pressure within the heart. The ventricles will secrete that BNP. If you remember, BNP is cardioprotective, and its function is going to be to decrease the blood pressure by increasing that excretion of sodium and water and promote atrial dilation. It achieves its effects by counteracting that renin, angiotensin, and aldosterone system. So it does the complete opposite. And so this whole process that we talked about is going to cause myocardial hypertrophy, because that heart is going to be working in overtime. So it's going to enlarge, which is going to cause heart failure. So some risk factors for heart failure: smoking, stress, high blood pressure, cholesterol, high cholesterol levels. What do we want to encourage our patients to do? We want them to be more active, because we know that physical inactivity is a risk factor for heart failure. Being obese, so we want them to have a better diet. Watch your alcohol, watch your sugar intake. We don't want them to get diabetes, but we know that comes along with inactivity, high cholesterol, being obese, and not being very active. All right, so when we're talking about our nursing assessment, some things that we want to look for. So we want to look for signs and symptoms of pulmonic and systemic fluid overload. We're going to talk about these in more detail. We are also going to, we're going to be listening to heart sounds. We're going to be looking at our patient's work of breathing. Are they using accessory muscles? Do they have advantageous lung sounds? Do we hear crackles? Do we hear wheezes? When we're checking their vitals, we're going to be checking blood pressure, oxygenation. What's their pulse like? Are they tachycardic? Are they bradycardic, depending on how far the heart failure has gone? We're going to be checking our extremities, our peripheral extremities, for edema. Do they have non-pitting edema versus pitting edema? What color are they legs? Do they have that dependent edema? What's going on? So we also want to assess to see if those compensatory systems that we just talked about have been activated. And then, is there evidence that our tissues are not being adequately perfused? So we said back a couple slides back that when these compensatory systems start to work, that it's going to shunt blood to the brain and the heart, but it's going to take away the kidneys. So what do you think one of the first things we're going to see is in our patients if that's happening and they're not getting good blood flow to the kidneys? Taylor.
Sorry, I got bit by a dog yesterday, so.
Okay.
What was it again? I was trying to get something.
So the question was, we wanted to look and see if there's evidence that our tissues are not being perfused. So a couple slides back, I talked about the fact that when our compensatory systems start to work, our body will shunt blood to our brain and to our heart because they think that's the most important place for it to be, but it's going to take from our kidneys. So what is a sign that you could see in the clinical setting that would indicate to you that our patient's kidney functions could be compromised?
Like the output, urine output decrease?
Yes, very good. So that's why we do strict isonos on our patients. So if we notice that our patients aren't putting it out at least 30 mLs per hour, that is a sign that our kidneys are not working. Or if the doctor's ordered labs, you can always look at their creatinine and BUN. And then those daily weights, those are going to be your first indicators. All right, so with left-sided heart failure, you're going to see hypoxemia. Your patients are going to have difficulty breathing. due to the decreased cardiac output and that backup of fluid into the lungs. They are going to have what we call exertional dyspnea. So they're going to have dyspnea on exertion. When they get up, they might appear fine in the bed. They're not using any accessory muscles, but if you're in the room passing meds and they walk to the bathroom, they're going to be visibly short of breath. If they're working with PT, they might complain that they're extremely fatigued after their session. It's going to take a lot out of them. They're going to have orthopnea. So this is the inability of your patients to breathe when they're sitting up. They might have paroxysmal nocturnal dyspnea. This is when your patients will wake up in the middle of the night when they're sleeping, and they're going to report that they're breathless and they can't really catch their breath. They may have an irregular or a rapid pulse, depending on how far the heart, how bad it is. So initially, you might just have that rapid pulse because your body senses the decrease in oxygen or the decrease in blood pressure. So the heart has to speed up how fast it's pumping out. Further down the line, if the compensatory systems don't work and it is left untreated, it can become irregular as things become worse and death is more imminent. We're going to see an elevation in blood pressure due to that activation of the sympathetic nervous system. Your patients may have a cough. They might have a bloody cough. We're going to hear moist crackles. We're going to see diminished urine output, might see cyanosis. This is where we're going to hear that extra heart sound, so that S3. You guys should know where you would hear an S3. And then these patients are going to have a cough with a pink frothy sputum. So if you hear cough with pink frothy sputum, sorry, you guys should think left-sided heart failure. Right-sided heart failure. Your patients might complain of a history of gradual unexplained weight gain. So some patients could say, I woke up and I gained 4 pounds from yesterday. That's not so gradual, but you do see that sometimes with patients who have chronic right-sided heart failure. Or they just might report, you know, over the past 3 or 4 weeks, I've gained like 5 pounds. I've noticed that my legs feel heavier. It's going to be from that fluid retention because that right-sided heart is not working. So all that blood is going to pool in those lower extremities. We're going to see dependent pitting edema because excess fluid is moving into the interstitial space. We're going to make sure when you're assessing your patients that you are actually pushing on their extremities, pushing on their legs, their thighs, check their arms, check that sacral area because we know we can see dependent edema in all those areas. They're going to be weak. If their sacral swelling is really bad, they can also have ascites. So when their abdomens are really protruded and swollen, they might even look pregnant. Hepatomegaly, which is when our liver enlarges. These patients are going to have JVD. So when you have them turn their head to the side, you're actually going to see that vein, that jugular vein distension, or you might see it pulsating. They're also going to experience dyspnea. But in this case, it's not going to be because the blood is backing up into the lungs. It's going to be because all of the organs are enlarged, and it's going to cause restricted breathing because all that fluid is pulling in their lower extremities and in their abdomen, and it's going to put pressure on their diaphragm. They're not going to be able to breathe properly. So I need you to understand where the dyspnea is coming from. It's 2 different issues, between right-sided heart failure and left-sided heart failure. They're obviously going to have weight gain. They're going to have nausea and vomiting because of that accumulation of that blood in those abdominal organs that's going to make them nauseated. They're going to feel sick. We're going to see arrhythmias. And then obviously that central venous pressure is going to be elevated. Oops. All right, so one of the clinical indicators that we use is a lab called BNP. We will pull this in our patients if we think they have congestive heart failure. This is the lab values that you may see in the clinical setting. So less than 100 indicates no heart failure at all. 100 to 300 suggests that heart failure is present. 300 to 599 indicates mild. 6 to 899 indicates moderate. Greater than 900 indicates severe heart failure. It is not uncommon to see patients that have these numbers upwards of 13,000. I've seen them from 7,000, 9,000, 13,000. So this is just the lab that we would look at in the clinical setting. Other diagnostics we could do that echo. The echo would show issues with ventricle enlargement or dysfunction with the ventricles. We could do what's called a MUGA or an ERNA nuclear scan. It is the most accurate, non-invasive test that we can do to, that is an indicator of left ventricular ejection fraction. We can also do it with the echo. So if we did the echo, it would also show us the ejection fraction for the left ventricle, and then it would show ventricular enlargement on the right side. We could do a chest x-ray. Chest x-rays for the left-sided heart failure are going to show cardiac enlargement and fluid accumulation in the lungs. The right side is going to be able to visualize that ventricular enlargement. We could do a 12-lead EKG, which would show right-sided issues with the ventricles. We could do a stress test or a cardiac catheterization. We're definitely going to want to look at those BNP levels. We want to measure their electrolytes. We know that anytime they are retaining fluid, that their electrolyte status can be compromised. We're going to be looking at BUN and creatinine because we want to see if all of our kidneys are being perfused properly. Hematocrit and hemoglobin. Sometimes they're going to change based upon our electrolytes. We're going to do ABGs. So initially, our patients are going to present with respiratory alkalosis. After it's left untreated, it's going to progress to metabolic acidosis as that gas exchange becomes even further impaired. We would want to check a fasting blood sugar. We know our blood sugar can change with our electrolytes and our potassium. And then we also want to look at thyroid function. So this is a heart failure algorithm. You guys can read over this. So pharmacologic interventions. So any type of intervention that we do is going to be directed at reducing the workload of the heart, because it's the heart that is having to jump into overload and work double time to accommodate for all the issues. And we want to improve cardiac output through dietary modification, drug therapy, and lifestyle changes. So we never look at heart failure and just say we're going to manage it with medications. We want to educate our patients about modifying their diet, really being compliant with those lifestyle changes. So cutting out sodium, eating foods that are high in protein, low fat, lots of fruits and vegetables, exercising every day, losing weight. We need to see lifestyle changes so that they can continue with the medication to manage their heart failure at home when they're in the community. We can give them what we call ACE inhibitors. ACE inhibitors work by suppressing the renin-angiotensin-aldosterone system. It's going to reduce water and sodium retention, which is going to lessen our blood pressure. It's going to relax the blood vessels, which is going to cause a decreased workload of the heart. So some of the medicines that we can give are benazepril. This can cause a spiked T wave. You guys need to know that. We can give captopril, enalapril or Vasotec, lisinopril or Prinavil. So you want to educate your patients if they're taking that benazepril that they need to follow up with their cardiologist if they're feeling any kind of heart issues. They would want to go to their primary care physician and get an EKG because it can cause that spike T wave, which can cause heart damage. We are going to want to educate them about sodium intake through their diet. This is huge. They need to decrease the amount of sodium they have in their diet. And then we want to encourage them to monitor their blood pressure at home. We can also give them ARBs, angiotensin receptor blockers. These inhibit the pressor effect of angiotensin 2. It suppresses that negative feedback loop and relaxes blood vessels, which eventually lessens the heart's workload. So we can give losartan or valsartan. Those are two of the most popular ARBs that we use. The thing with all these medications that I want you to understand, whether they're ARBs, ACE inhibitors, diuretics, we need to do a lot of education about monitoring their blood pressure. We don't just want them to monitor it once a month. We ideally want them to monitor it every day. They should monitor it every day before they take the medicine. Is that realistic? Probably not. Some patients will, some patients won't. We want them to monitor it because we need to know if it's controlled. We also need to know if it's too low. So we talk about this all the time. We try and fix one problem and then we cause another. So they should be monitoring their pressure every morning before they give their medication. We do it in the hospital as nurses. Before we give our blood pressure medicines, we always do vital signs just to make sure their blood pressure is high enough and actually indicative of receiving the medication. So educate them to monitor that blood pressure. We want to teach them about sitting on the side of the bed in the morning when they get up, or anytime when they go to get up. They should always sit at the edge of the chair, at the end of the bed, make sure they don't feel dizzy, dangle their feet over the side of the bed or the chair, and make sure that they feel okay before they stand up. We want to implement those safety precautions. All right, so diuretics, these work by decreasing the work of the heart by promoting excretion of sodium and water, which in turn will reduce our circulating blood volume. So we can give Bumex, furosemide, which is also Lasix, chlorothiazide, which is also diuryl. These are some of the most common diuretics that we use. And again, the big take home there is monitoring the blood pressure. We have beta adrenergic blockers, so these reduce our heart rate and decrease consumption of oxygen by the myocardium. So we can give bisoprolol, which is Zebeta, carvedilol, which is Cureg. We can give metoprolol, which is low pressor. So metoprolol, you will see, is pretty much the gold standard for AFib, but we do use it. You do see it used in patients who have heart failure and blood pressure issues as well, but mainly we see it used for AFib. We can give cardioglycosides. So these increase our cardiac output by slowing our heart rate and increasing the force of the contraction. So these medications, one is going to be digoxin or lanoxin. You need to know about that medication. Geriatric considerations for toxicity. So we know that our geriatric population is extremely vulnerable to all issues, right? Our babies and our older people. Because of our impaired liver function or decreased liver function and kidney function as they get older, everything starts to slow down. It's very common that with all medications, they are at risk of suffering toxicities. And digoxin is one of those medicines. The medicine can build up in their system and cause toxic levels. So it's extremely important that we monitor these digoxin, lanoloxin levels with our patients. So you guys should be marking that down. You're going to see that again on your exam. Vasodilators. These dilate our coronary arteries, which improve our heart's pumping action, and it helps maintain our blood pressure in patients that have severe heart failure. So those medications are going to be nitroglycerin and isosorbide. So some of the nursing diagnoses that we would see for heart failure, we're going to see decreased cardiac output. Could be related to ineffective ventricular contraction, tachycardia, reduced stroke volume, hypertension, and increased vascular volume. We can also see excess fluid volume related to reduced renal function, which is going to be caused by that increased antidiuretic hormone, and then aldosterone production and reduced cardiac output. We're going to see impaired gas exchange related to pulmonary congestion, secondary to that left ventricular dysfunction. Activity intolerance related to hypoxemia being caused by that decreased cardiac output and then that pulmonary congestion. And then risk of hypokalemia related to the excretion of potassium secondary to those diuretics that we're giving. All right, so when we are evaluating our patients, when we're evaluating those nursing interventions and our teaching, we have to look at our patient's ability to manage themselves at home. The patient should have a good understanding and a knowledge of the following issues. So they should know what to do when pain occurs. So if they're having pain in their legs, if they're having chest pain, obviously chest pain is a medical emergency, they need to go to the emergency room. If they have angina because of other heart issues, we know sometimes that we can give them nitroglycerin. After a couple minutes, if that doesn't work, they can take another. We usually give them 0.4 the first time. If that doesn't work, they can take another 0.4. If it doesn't help it and the pain continues to get worse, they should think about coming into the emergency room. We want them to maintain and improve their physical strength and mobility. They might not be able to do a lot when they're actively having an exacerbation of heart failure, but as it starts to improve, we want them to work with physical therapy if they're doing home physical therapy. We want them to start walking. We want them to stay active. Because when they do have an exacerbation, it's very debilitating. So if they already have a good physical strength coming in, it's going to be a better outcome for them. We need to teach them to monitor their weight. Every single day, they have to monitor their weight, even if they're not having symptoms. Because if they don't have a baseline of where their weight is, they're never going to be able to tell if they're having an exacerbation. They need to be able to recognize those little 1 pound increments, because an increase of 1 or 2 pounds is going to make a big difference. And that is indicative of heart failure exacerbation. So monitor that weight every day, same time, same clothes. Dietary therapy is very important. They don't want to have a lot of sodium in their diet. Sodium restricted diets are best, no sodium at all. Some patients are going to be on fluid restrictions, so they're going to monitor how much they're taking in every day. They want to avoid gas-forming foods. Remember, we said some of those patients, with the right-sided heart failure, everything backs up and their liver enlarges, their kidneys, they get all that abdominal swelling. So any kind of gas-forming foods is going to contribute to worse abdominal distension and pain, and it's going to make it more difficult to breathe. And then small, frequent meals to help avoid that abdominal distension. It is imperative that they take their prescribed medications every day as they're supposed to be taken. Don't skip any doses. Make sure they're being diligent with that. Keep those follow-up appointments with their primary care physicians so that the doctor can monitor their heart failure, make sure that they're doing okay, give prescription refills when they go, check their weight, all that good stuff. And then they should understand that heart failure is a chronic condition and that management focuses on lifestyle changes and medications because we need to prevent these acute exacerbations. So potential major complications of heart failure, we can see pulmonary edema, we can see cardiogenic shock, dysrhythmias. We're going to talk about cardiogenic shock later in this lecture. Thromboembolism, pericardial effusion, and then cardiac tamponade. We talked about these a couple lectures back. So client and family teaching. So not only are we teaching our clients, but some of our clients are cared for by their family members. So we also need to teach our family members as well. So we talked about monitoring that blood pressure daily because we need to make sure that it's controlled. We also want to monitor their pulse. A lot of these medications that we give them control their blood pressure and the pulse. So with metoprolol, that is one of the things that reduces the workload of the heart. So when we reduce the workload of the heart and we mess with that contraction, those are medications that are going to control our pulse and our blood pressure. Some of our medications just control our blood pressure. So if you're on a medication that decreases the workload of the heart and that contraction rate, you're going to want to tell your patients to monitor their pulse and their blood pressure. So you're going to want to make sure before you send these patients home that they can do a teach back to you. You can teach them how to do it, but then you want to see them do it. You want to make sure that they can actually find their pulse and that they can count appropriately. So you would do it once and get the number, have them do it and make sure that it's accurate. We want them checking their weight at the same time each day using the same scale. Consult a physician if you have a gain of more than 2 pounds in 24 hours. Okay, you guys need to know that. More than 2 pounds in 24 hours. Schedule rest periods throughout the day to reduce or eliminate fatigue and dyspnea. We want them to increase activities such as walking when they're able to do so without being short of breath and without getting tired. If they're still walking around their house to the bathroom and the kitchen and they're severely dyspneic or they feel exhausted, we don't want them taking a 2-mile walk around the block. So we need to make sure that they do these activities. We want them to walk, but when they're feeling better. Identify and avoid occasions that produce stress. Elevate their legs when they're sitting, and then follow the diet prescribed by their physician. We want them to avoid extreme heat, extreme cold, or humidity. Report a heart rate of less than 60 or more than 120 beats before taking one of the medications that we talked about was digitalis. So we need to make sure that their heart rate is above 60 and less than 120. And we want to contact the physician if symptoms return or if they see swelling in their legs, their ankles, or feet suddenly. And then obviously maintaining that follow-up care is very important, keeping all those appointments. So we said one of the things that we could see as a result of heart failure is pulmonary edema. So pulmonary edema is an acute emergency. In the picture here, you can see this is the lungs right here, a normal set of lungs on the left. Over here, you can see what pulmonary edema looks on the right. You can see how it affects all those bronchioles. You're not going to get a lot of airflow in there. So it is a frequent complication of left-sided heart failure, because remember we said in left-sided heart failure, the fluid is backing up and it's going into our pulmonary system, our lungs. So pulmonary edema, left-sided heart failure, fluid accumulation in the lungs. It's going to interfere with our gas exchange in the alveoli. The right ventricle continues to pump. The left ventricle can not empty properly, and fluid is going to accumulate in the left atrium and the pulmonary veins. The lungs will fill rapidly, and we're going to see respiratory distress. So sudden signs of symptoms, they're going to have sudden dyspnea. All of a sudden, they're going to report shortness of breath. They're going to have wheezing. They're going to have that orthopnea that we talked about. They're going to be restless. They're going to have that cough, often with pink, frothy sputum, which is indicative of left-sided heart failure. They're going to have cyanosis. They're going to have tachycardia, and they're going to have severe apprehension or anxiety because they're not going to be able to get good airflow in. And they're going to feel apprehensive, obviously. It's very scary not to be able to breathe. So what management are we going to do? We need to rectify that lung congestion immediately and as quickly as possible. So we're going to give these patients oxygen because they're not getting oxygen right now. All that blood circulating doesn't have that good, rich oxygen. So we need to put them on nasal cannula or a mask, depending on how severe their oxygen is. They might require mechanical ventilation, so they might be upgraded to the ICU, and then we're going to give inotropic medications. All right, so cardiogenic shock is also something that we can see as a result of heart failure. Cardiogenic shock occurs when the heart is unable to supply enough blood to all the vital organs of the body. The blood pressure falls and organs begin to fail. We're going to talk more about this a little further down, but this is a nice slide to show you actually what's going on in the body. These are the different arrhythmias that we may see. This is actually a good sheet for you guys to look at for studying. Got your V-fib in there, your A-flutter, your A-fib, your sinus brady, sinus tachycardia. We know that they are at risk for venous thromboembolism. So what side heart failure do you think that you are going to see that risk of thromboembolism is? Do you think it's going to be the right-sided or the left-sided?
Left-sided.
What side?
The left-sided.
It's actually the right side. Right side because it's all that blood is pulling, right? It's not being able to get back to the right side of the heart. So it's going to pull and it's going to go all the way back down into those lower extremities. The blood's just going to be sitting there. With left-sided, it's going to be congested and stuck in the lungs. Okay. This is a picture of a normal heart on the left, and then we see what happens if our patients have a pericardial effusion. You can see all that buildup of fluid. And this is what it would look like on an X-ray. So a pericardial effusion is the buildup of excess fluid in that sac-like structure around the heart, which we call the pericardium. It puts pressure on the heart and it affects the heart's function. If left untreated, it is going to cause heart failure or death. Signs and symptoms of a pericardial effusion: shortness of breath or difficulty breathing, so dyspnea, discomfort when lying down, orthopnea. So most of these patients will say the only way that they can breathe is sitting up. Chest pain, usually behind the breastbone or on the left side of the chest. They might report that their chest is full because they have all that fluid in there. And then we're going to see swelling in the legs or in the abdomen. We could see a cardiac tamponade. This happens when all that extra fluid builds up and it puts so much stress around the heart and it prevents it from pumping. And then coronary artery disease. Obviously, this is a great picture. This shows what a normal, healthy artery looks like. B is an artery with a buildup of that cholesterol plaque, which is going to cause a narrowing. And then C is an artery showing plaque rupture with an emboli in there. So you can see if you can't get blood flow through those arteries, you're going to have significant heart issues. All right, so coronary occlusion, this happens when we have the full closure of a coronary artery, which reduces or totally disrupts blood supply to that distal muscle area. So coronary artery disease does precede coronary occlusion, obviously. You're going to see that buildup of plaque or cholesterol in the heart over time, and then eventually, as it continues to happen, you're going to see that coronary occlusion. Left untreated, this is going to lead to a myocardial infarction, because if the blood flow can't get through, your patient's heart can't get a good supply of blood. So it's going to cause that heart attack. And then symptoms do not usually occur until there's at least 60% of an occlusion. So for the longest time, this is occurring and patients don't have any idea. Once we get to that 60% of that arterial inclusion, that's when the patients are going to start seeing those chest pains, dizziness, shortness of breath, things like that. So coronary artery disease is arteriosclerotic and atherosclerotic changes in the coronary arteries that supply that oxygen-rich blood to our myocardium. So we have inherited factors. So it occurs usually 15 years earlier in the male compared to the female. We do see a higher incidence in postmenopausal women. It happens pretty rapidly once they start going through menopause. Women with a family history of coronary artery disease show evidence 7 years sooner than women with no history in their family at all. So these are things that you guys want to consider when you're dealing with populations in the hospital, when you're taking care of men and female. These are things that you want to keep in the back of your mind. We do see a correlation with coronary artery disease and patients that have diabetes mellitus, because we know that one of the cause of diabetes is not having a good diet intake. It's also from being sedentary and not exercising. So diabetes, poor diets, being sedentary, they're all associated with high cholesterol levels as well, increased lipid levels, and then hypertension. So some behavioral risk factors. So that sedentary lifestyle, being obese. So you guys need to know your BMIs, right? So you can see who would be at risk for coronary artery disease, smoking, competitive personalities, and high-fat diets. And then people who are aggressive tend to have coronary artery disease, I guess, because of the stress. So this is another good picture. On the left is a picture of a nice healthy lumen. You can tell there's no blockage in there. All the blood flow is going to go right through. The smooth muscle looks great. If we look at the picture on the right, you can see that it has that partial obstruction with plaque or cholesterol. So you know that there's going to be issues with getting that good blood flow through with that lumen in that picture in B compared to the one in A. So assessment findings, what are we going to see in our patients? So they could be asymptomatic, right? Depending on how far the plaque has progressed, how much they have, what the occlusion is like, or they could present with fatigue. They might have chest pain, which we call angina, that will radiate, it can radiate from the chest to the shoulders down to the arms, especially on the left side. It can go to the jaw, the neck, or the teeth. So these are the common findings that we see. Remember, we talked last week that women exhibit more atypical symptoms, such as just nausea, fatigue, dizziness. It's often overlooked and misdiagnosed. How many times have we woken up and we've just been more tired, especially being in nursing school, or we just feel nauseated, or we just feel a little dizzy, but then it subsides. So looking at our patients that are exhibiting those atypical signs and looking at their history, putting the pieces to the puzzle together to see who could be at risk. And then, you know, some patients might say, yes, I just have chest pain on the left-hand side. It doesn't go into my arms. It doesn't have to go into their arms. It doesn't have to go into their back or into their jaw. It's different for each person. Some patients just complain of indigestion, another thing that's very easily overlooked for a long period of time. They might also report burning, squeezing, tightness in the upper part of their chest, or sometimes in their throat. So what kind of diagnostic findings are we going to look at? Well, we definitely want to look at our lipid profiles. We want to look at their cholesterol. We want to see the fat that's in the blood. So we're going to look at their total serum cholesterol. This is the total of the LDL, the HDL, and the triglycerides all together. We want to look at our low density lipoprotein. So our LDL is our bad cholesterol. There's a lower ratio of protein in our blood to cholesterol. Our high density lipoproteins, our HDLs, are our good cholesterol. Our good cholesterol has a higher ratio of protein to cholesterol. And then we want to look at our triglycerides. We can also do an electron beam computed tomography. This is going to look at the different calcium deposits in the heart. We can look at exercise, electrocardiography, so those ECGs. We could also do a cardiac catheterization, which would directly visualize that blockage, and they could go in and open it up, get rid of it, put in a stent so that we get that good blood flow going again. An arteriography, and then we can do stress testing. We've talked about all these tests in details in previous lectures. So how are we going to control it? Well, one of the main things we're going to do, what we consider our first line of defense, is we're going to encourage our patients to have lifestyle changes. So if they're obese, we need them to lose weight. We need them to be able to practice stress management. They need to be able to control the stress in their life. We wanted to monitor their blood glucose. If they're smoking, they need to stop, and they need to start exercising. And we can also, in conjunction with those lifestyle changes, because remember, we never just do medication, we do medication and lifestyle changes. We can give nitrates, which are going to help with that angina. We can give those beta adrenergic blockers. We can give calcium channel blockers, ACE inhibitors, diuretics. Definitely are going to give those lipid lowering agents. So your atorvastatin, which is your Lipitor. We're going to give anticoagulants because we want that blood to be thin. And then we want to give supplements of folate or folic acid, vitamin B6, and vitamin B12. Sometimes our patients are going to require surgical management because of that occlusion, depending on how much of an occlusion they have. So we can see a percutaneous transluminal coronary angioplasty, PTCA. This is where they go in and they put a balloon and they open everything up, and that promotes good blood flow through, getting to the body, to the heart. We can put in that coronary stent, which is a small metal coil that has mesh on it. They place that in the coronary artery, and that good blood flow can get through again. All these are in your book. You can read more about them in detail, and they show some pictures. We can do an atherectomy, which is where they go in and they remove that fatty plaque. What we see a lot of patients have is what we call a CABG. It's a coronary artery bypass graft surgery. So you'll notice when nurses give you a report, they'll say, Mrs. Jones has a past medical history of a CABG ×2, a CABG ×3, maybe even a CABG ×4. That would be indicative of how many arteries they had to bypass, so how significant their blockage was. Some people it's only 2. Some people they have a lot of blockages and they have to do it by 4 arteries. So CABG ×2 would be 2 arteries, CABG ×4 would be 4 arteries. They take a section from a healthy leg vein or a chest artery is used to reroute the flow of that oxygenated blood from the aorta or a chest artery to below the obstruction in the diseased coronary artery. We can also do a transmyocardial revascularization, a TMR. This is for clients that have chest pain that don't respond to medication and for patients who are not candidates for CABG therapy, surgery. So nursing management, what are we going to do as the nurse? Well, we're going to make sure when we're doing our assessment, we're looking for those characteristics of chest pain. Tell me more about your chest pain. Does it radiate to one side? What arm does it hurt in? Does it go into your back? Do you have numbness and tingling in your hands? Does it feel tight? Does it feel like you have pressure? Does it feel like someone's squeezing? And then we're going to administer those prescribed medications that are going to help dilate that coronary artery or reduce the workload of the heart, or both. Sometimes they take medications that do both. We want to preserve their energy. We don't want them to do anything that's going to increase their heart rate if they already aren't getting the proper blood flow through those arteries. So we want to encourage rest. We want to administer oxygen because that's going to help improve the oxygen level supply that we get to the heart muscle. We want to educate our clients to reduce those modifiable risks, right? Stop smoking, modify your diet, start exercising. And then we want to make sure that we're preparing our patient for any diagnostic tests that they need to have or any treatment procedures. So we know if our patient is going for any type of a procedure where they could be at risk for bleeding, we need to make sure that we're not giving them any anticoagulant therapy, usually about 6 to 8 hours before. And it's very common, I see it happen all the time. The doctors forget the night before to discontinue these medications, and they'll be listed on the MAR for you to give with your morning meds. So you need to recognize, hey, my patient's having a procedure today, an invasive procedure where he could possibly at risk for bleeding. I don't want to give this anticoagulant. And then when your patient comes back from having that procedure, you're going to want to make sure you're monitoring all those vascular sites for bleeding, checking all those distal pulses, making sure you have good color and good pulses, make sure there's no drainage coming out of those sites where they went in, make sure the pressure dressing is clean, dry, and intact. So some nursing diagnosis we might see would be deficient knowledge related to, it could be unfamiliarity with those diagnostic tests, some preoperative preparations, postoperative care. It might also be deficient knowledge regarding lifestyle management, so exercising, eating properly, anxiety related to potential surgical outcome, acute pain related to surgical trauma to the skin and operative tissue, or it could just be the chest pain from the angina. Risk for ineffective airway clearance related to ineffective cough secondary to pain and those accumulated secretions in response to an artificial airway that we put in for some of these tests that we do. They're at risk for impaired gas exchange related to retained secretions, hypoventilation secondary to pain, and then displacement of certain chest tubes that they might have. They're at risk for decreased cardiac output related to impaired ventricular contraction, risk for infection related to impaired skin, and then always at a risk for hemorrhage after they've had those procedures. All right, so now we are going to talk about iron deficient anemia. It looks like we're about halfway through. Do you guys want to take just like a 5-minute break, or do you want to wait till about 9:30? Yes, everybody wants a 5-minute break. Okay, all right, 5-minute break, and then we will come right back. We're going to talk about iron deficiency anemia. This is a very common finding that you're going to see in a lot of your patients. So it's important for you guys to know and be able to recognize it in the clinical setting. So anemia is a deficiency of either erythrocytes or hemoglobin. So erythrocytes are those mature red blood cells to which the hemoglobin actually attaches to, and their function is to carry oxygen to all of the cells and to transport carbon dioxide to our lungs. Most of the time when we see anemia in our patients, it is either because of blood loss, so blood loss related to if they have a particular bleeding disorder, it could be an acute or a chronic issue, or if they've had some type of acute or chronic loss. It can also be a result of inadequate or abnormal erythrocyte production. And then it can be the destruction of normally formed blood cells. We see these in certain hereditary disorders or in the instances of hemolysis hemolytic anemia. And we're going to talk more about these. So the most common types of anemia that we see is hypovolemic anemia, iron deficiency anemia, pernicious anemia, folic acid deficiency anemia, sickle cell anemia, and hemolytic anemia. So the signs and symptoms that we see of these different anemias are always going to be based on, first of all, the severity. So is it an acute issue or a chronic issue? And then we're also going to see the signs and symptoms depending on the speed at which it developed. The metabolic needs of the patient are also going to have an effect on the different signs and symptoms that we see. And then any other problems or comorbidities that we have will also have an effect on those generalized signs and symptoms. So things that we could see in our patients related to an inadequate red blood cell volume, we could see orthostatic hypotension. So you guys know what that is when you're changing positions from laying to sitting to standing. You'll see that drop in systolic or diastolic blood pressure. We might see a thready pulse. In some cases, oliguria, and then we might even see heart murmurs. So when we have anemia, we also have more compensatory mechanisms that will kick in to try and fix things when we have that loss of red blood cell function. So we're going to see tachycardia because we are not getting enough oxygen because we don't have enough red blood cells, so the heart thinks it needs to pump out more. We're going to see tachypnea. We're going to see cool, clammy skin, amnuria, decreased red blood cell function. These patients are going to be dyspneic. They might complain of chest discomfort. We might see acidosis, headache. They might complain of vertigo, pallor, constipation, difficulty concentrating, and decreased bowel sounds. So that difficulty concentrating, that's going to happen as our oxygen supply becomes more deficient and our brain isn't being perfused properly. The decreased bowel sounds and the constipation, that's because our GI system is not getting perfused like it should. So the IDA assessment. So iron deficient anemia is the most common type of anemia that we see. The cause is that the heme in our blood cannot be recycled due to either blood loss. So the patients had some type of blood loss in the body, surgical trauma, through their period, whatever. We're going to talk about that. Their dietary intake of iron is not sufficient. Or the absorption of the iron from their food is inadequate, or the need for iron, their body's iron need, exceeds the reserve that they have. So some of the risk factors, we're going to see patients who have compromised nutrition. So when we think of compromised nutrition, we want to think about the different things that could cause our nutrition to be compromised. So maybe it's that it's an older adult, maybe they've had a stroke and they can't feed themselves. So they're not able to feed themselves properly. Maybe they don't drive anymore and they don't have any family close by and they can't get nutritious food from the store. Maybe they don't have the ability to cook them for themselves, so they're making unhealthy food choices. So there's a variety of things that can compromise a person's nutrition. Do they have access to healthy food? Do they have a lack of knowledge about nutrition? Maybe they don't know how to read food labels. Maybe they don't know how much iron they should have or what type of foods have iron. Do they have maybe a malabsorption disorder, so their bodies just can't absorb the iron? In patients with pregnancy, when they're pregnant, we know that their bodies require more iron. So sometimes it's they need to have an iron supplement. Adolescents, during periods of rapid growth, our adolescents require more iron intake. We see it a lot in females because they have their menstrual cycle, and some people lose a lot of blood more than others, so their iron becomes deficient. And then again, those gerontologic considerations, you know, the old people, they're always at risk for all the issues. All right. So general anemia symptoms. So in the early stages when you still have iron stored, but they're starting to be depleted, you might not have any symptoms at all. So they're going to be asymptomatic. They might complain of weakness, fatigue. They might exhibit pallor. They also might have something called pica. So pica is when patients crave ice, certain starches, or dirt. So they will actually eat dirt or ice. They eat strange things. That's called pica. They might complain of being cold all the time. They might have dyspnea with exertion because they're not going to have that good circulating oxygen due to the lack of red blood cells. And then their heart rate is going to be rapid even at rest. For prolonged deficiency, we're going to see tongue soreness. We're going to see brittle and rigid nails, ulcerations in the corner of the mouth, and then hypoxia. So signs and symptoms of compensation. So these are the mechanisms that our body is going to do to fix the problem. So we're always going to look at signs and symptoms, but we're also going to look at those signs and symptoms of the body trying to compensate. So the heart increasing, so tachycardia, palpitations, dyspnea, dizziness, and then if left untreated, we're going to see the development of heart failure. So when we look at labs, we're going to look at their hemoglobin and their hematocrit. They're going to obviously show decreased. We're going to look at those serum iron levels. They're going to be also show a decreased level. And we're also going to look at the erythrocytes. So when we look at them through cytology, they're going to appear smaller than normal. So that would be considered microcytic. And we can have hyperchromic. So they're going to be lighter in color than normal. And then we would want to, when we see decreased hemoglobin levels and iron levels, we have to think to ourselves, what's causing it? Does our patient have a bleed somewhere? Did they just have surgery? Is it a female patient and maybe she has fibroids or she just had her period? So you always want to think, what is causing this low level? So one of the things we think about a lot in the hospital setting is, do they have a GI bleed? So we would want to send off for that stool culture for an occult blood to see if there's any stool in the blood at all. And then when we look at our patient stool, we want to look to see if we see any dark stool. So dark stool would be indicative of an older bleed or an upper GI bleed, and then bright red blood is going to be a sign of an active bleed or a lower GI bleed. So certain assessments that we want to do to determine the cause of the anemia. So we're going to do that nutritional assessment. We want to improve their nutritional intake of iron. So we need to know, what does their daily intake look like? Have the patient sit down and go through an entire day of what they eat, meal by meal. What kind of snacks do they have? What does their intake look like? And then it might also, based upon your assessment, it might require collaboration with a dietitian. So if you're in the hospital setting, you always have access to a dietitian. If you're in the primary care setting, then you would have to give them a referral, to someone outside the office. You want to do a medication history to see if there's any medications that could be causing this. We want to do a family history. Is there any genetic components? Because we do know that some issues that cause iron deficiency can be genetic. And then we're going to do that GI assessment. So we're going to look for abnormal bleeding, GI bleeds, ulcers. We want to do a neurologic assessment because we want to assess their are they alert and oriented? Do they have any type of oxygenation issues that are affecting their cognitive ability? And then if we are talking with women, of course, we want to get some more information about their menstrual history. So what do their cycles look like? Are they regular? Do they come every 28 days? Do they come every 14 days? Do they last 3 to 4 days, or do they last 12 days? These are going to be indicative of issues that can cause anemia. So risk factors, we know that blood loss is a factor. So GI bleeding, stomach ulcers, certain cancers, patients that have hemorrhoids, excessive menstruation, any kind of trauma. So gunshot wounds, stabs, abdominal injuries, car accidents, recent surgeries, frequent blood draws. And then we know that they can also have dietary deficiency, so not enough intake through their diet. So vegans and vegetarians, we see this a lot with them. Patients who suffer with abuse of alcohol over the long period of time inhibits the body's ability to absorb vitamins. So you'll see that one of the things that we do for them when they come in is we pump them full of vitamins. We call them banana bags. They're big yellow bags, and they're just filled with vitamins. And then poor food choices. And the poor food choices can also be related to the alcoholism because they're drinking all the time and they're not really eating. Certain medications, so the use of antacids will also prohibit the absorption of iron. Patients that have had GI surgeries or gastric bypasses, certain GI diseases, and then fibroids that we see in women, these all cause the inability of their body to be able to absorb iron. And then in our pregnant patients, they have inadequate iron supplementation because their body requires more. And then we also see some excess bleeding after delivery, which can also deplete those iron stores even more. So laboratory values, so if the rate of the iron loss is greater than the amount being absorbed, usually absorbed through our GI tract, then the stored iron starts being used to make hemoglobin and red blood cell counts. Ferritin levels are stored in our body as iron. Our ferritin levels begin to decrease, as do the hemoglobin levels. Serum iron levels will decrease at this point, and the TIBC will which is the measure, is going to rise. The TIBC measures the level of our transport protein, of our transferrin. that are in the blood, but that are not carrying the iron. So when we look at our ferritin levels, they're going to be decreased. Our hemoglobin levels are going to be decreased. Our serum iron levels are going to be decreased. The TIBC levels are going to be increased. Our hematocrit is going to be decreased. Our red blood cell count is going to be decreased. And the mean corpuscular volume is also going to be decreased. There's a lot more information about these labs in your book if you want to read about them. Some nursing diagnoses that we might see. So remember that when we're planning care for a patient with iron deficiency anemia, our goal is to ultimately restore and maintain the iron at normal levels. So we want to replenish them, but we also want them to keep those levels there so this doesn't happen again. So some of the things that we identify are fatigue related to decreased oxygen level, decreased oxygen carrying ability of the blood, altered nutrition, less than the body requirements of iron. We might see altered tissue perfusion related to blood volume, reduced blood volume and H&H, and then non-compliance with prescribed therapy. So sometimes people don't take iron because it's very, very constipating, like very constipating. They can have a hard time. They won't go for days. It can be extremely painful when they do go. So a lot of people, especially when they're pregnant, they don't take it because of that. So you want to educate them about that. Sometimes it'll turn, in the PO form, it will cause their stools to turn black. That can be alarming, so people stop taking it. So if we educate them ahead of time about what they need to be compliant with the medication, 9 times out of 10, they will be compliant because they can make the changes to accommodate for the side effects. So with these patients, we want to prioritize their activity. So we want to balance their activity and their rest. We want to make sure we're giving them periods of rest. We want to encourage healthy diets. We want to limit their alcohol consumption, give dietary supplements as ordered by the doctor. And then we also want to encourage them to not take extra supplements that include iron, because then we could give them too much iron. So we're going to monitor their pulse ox, their vital signs, especially their blood pressure and their oxygen. We are going to promote medication compliance. We're going to monitor and manage any signs of heart failure. And then we're really going to do a lot of education. So we're going to encourage those diet changes and talk about all the foods that are rich in iron. We want to encourage our patients to be able to read their food labels. We want to talk about safety issues related to blood loss. So if they've had any kind of recent surgeries, maybe they're a high fall risk now, standing up, getting dizzy, making sure they sit at the end of the bed before they stand. We want to keep medications that contain iron out of the reach of small children because if they accidentally ingest it, it can actually be fatal. So foods that are high in iron, so beans, black beans, garbanzo beans, pinto beans, all the beans, egg yolks, fruit, especially our dried fruit, so our prunes and our raisins, our grains, so whole grains, iron fortified grains, breads and cereals, meats, poultry, fish, shellfish, especially red meats and organ meats, so that's going to be your liver, nuts, dark green leafy vegetables, and then we can also refer them for nutritional counseling. So when we talk about giving our patients iron supplements, so we can give oral supplements, which would be your ferrous fumarate, ferrous gluconate, ferrous sulfate. These are all just a different variety of PO supplements that we can give. The teachings that we want to do with those. So we want to avoid taking iron together with an antacid because it's going to interfere with your body's ability to absorb the iron. So they never want to take them together. We do recommend that they take the iron on an empty stomach unless they have gastric upset. Then they would want to take with food or whatever they're eating. It can just be a small snack. It doesn't have to be a meal, just something to coat their stomach. We want them to avoid dairy, chocolate, eggs, and caffeine for at least 1 hour immediately after meals. Drinking orange juice or taking other forms of vitamin C with iron will help promote its absorption. Dilute liquid preparations of iron with another liquid, such as juice, and drink from a straw. So iron tastes awful, terrible. So I always like to put it in some type of a juice, and I tell them that right up front that it doesn't taste very good. I'd like to put it in some type of juice. This is the type of juice I have. Which do you prefer? And then it will stain your teeth yellow. So give them a straw to drink it with. We also want to explain to them that they should be expecting the iron to change their stool dark green or even black so that they don't become alarmed. We don't want them to stop taking it. And then that they should contact the prescriber if they have constipation. So if they have constipation, obviously we are going to want to encourage them to increase their fiber intake. Or if they get diarrhea, we don't want them to have diarrhea. So we can also give parenteral supplements. So we can give IV iron dextran or iron sucrose. So we give the IV when they require a higher dose or if they can't take the PO route. So these would be your patients that have had strokes, that have some kind of dysphagia, they can't swallow, or they're NPO. We can also give an IM dose, which is given via the Z-Track. You guys can look in your book about the Z-Track method. It's where you pull the skin up, you inject it, and then you let the skin back down again, and it rests in that area. Usually when we give this, the IV is a little bit diluted. We can run it with some other type of fluids. It may cause a severe allergic reaction in some people. Sometimes what they'll do is the pharmacy will call down and say, let me know when you're ready to give this medication, because they won't prepare it until you're ready to give it, because it's only good for a certain time. So they're going to deliver it and you are expected to hang it as soon as it gets to the floor. So you want to make sure your schedule is available. And then sometimes they will give you a very small test dose that you give the patient, and then you monitor them for a couple minutes and then see if they have any kind of allergic reaction. And then if they're fine, then they'll send down more. Some of the things that we see with iron is a delayed reaction, like 1 to 2 days later. So this is something you want to educate your patients about. And then you're also going to want to, these are important things you're going to want to hand off in your bedside report with the next nurse. Hey, I gave this IV dextran today. This is the time I gave it, because you want to be able to know when that 1 to 2 days later is, so that every nurse after you can follow for that delayed reaction. Those patients that experience that reaction will have kind of like flu-like symptoms. So they might have a fever, body aches, stuff like that. And if that happens, then you definitely want to notify the physician. So evaluating our care. So our patients, we will know that our interventions have been effective if our patients' iron deficiency related labs return back to normal or they start trending normal. Sometimes we don't always see, especially in the hospital setting, we don't see a complete fix of everything. We just see that patients are stable and things are going in the right direction. And if that happens and they're stable, then they go home. Their symptoms may start to improve within a few days of treatment, but the recovery is a slow process. Usually the cause of anemia is corrected in about it takes about 3 to 6 months for that body's iron store to be completely replenished. So this isn't something that we're going to see in the hospital. We're going to see those labs start trending in the right direction, but we want to tell them it's going to be about 3 to 6 months before you feel 100% again. So they still might be tired. Complaining of that fatigue. The cause may never be discovered, or it may not even be correctable, and they may require lifetime treatment. I have seen patients that come in and we do every test under the sun, endos, colonoscopies, all the tests, and we can never really figure out where they're losing that blood from. And then sometimes it is just a lifetime process. Like if it's an autoimmune disease where your body just keeps attacking your blood, it's going to keep happening. So they require lifetime transfusions and iron infusions, things like that. And then we would want to be mindful of goals that we were not meeting so that we could make modifications in their plan of care if the patient is not making progress. All right, so shock is a life-threatening condition. It is a condition where we have inadequate oxygen and arterial blood flow to our tissues and our cells. It's going to cause a decrease in our circulating blood volume. It's going to cause heart failure because it's not going to pump effectively, and it's going to cause a peripheral blood vessels to dilate. If left untreated, we are going to see organ damage or death. So shock is very, very serious. We have 4 categories of shock. So we have hypovolemic shock, which is hemorrhagic. We have distributive shock, obstructive shock, and cardiogenic shock. So those are the 4 categories. When we talk about distributive shock has another sub-module of categories. So under distributive shock, we can also have neurogenic shock, septic shock, and anaphylactic shock. And we're going to talk about all these in detail. So hypovolemic shock is when we have a decreased blood volume with decreased filling of the circulatory system. It's very, very, very common to see this with hemorrhage. It's going to be frank red blood, internal bleeding, patients that have had C-sections, gunshots, stab wounds. They do a colonoscopy and they hit something and there's bleeding, internal bleeding or bleeding that you can see on the outside. We can see it with extreme diureses where we're really decreasing, pulling all that fluid out and really decreasing that circulating blood volume. We can see it with severe diarrhea or vomiting because that's also affecting our amount of circulating volume. Patients that are dehydrated. And then remember patients that have third spacing. So that's when all the fluid's moving out of the cells, it's going into that interstitial space. It's not effective fluid. So it's moving out of it's affecting we still have the volume in our body, but it's not in our circulating volume. It's being distributed somewhere else in the body and the body's not able to use it for anything. It's just sitting in that third area. With distributive shock, this is going to be enlargement of the vascular compartment and redistribution of intravascular fluid from arterial circulation to the venous or the capillary areas. So we said there were 3 different subcategories. So we have neurogenic shock, which we see very commonly in patients that have spinal cord injuries. We have septic shock, which is a toxic reaction to a gram-negative bacterial infection. We're going to talk about these in detail, but septic shock is something we see all the time in the hospital with flu, with UTIs, when it goes to your blood system. That's when a patient's thought to be septic. And then anaphylactic shock, which is a severe allergic reaction. So that's your distributive shock. Obstructive shock is impaired filling of the heart with blood due to some type of a mechanical impediment. So patients that have that cardiac tamponade from them pleural effusions or them pericardial effusions, patients that have a dissecting aneurysm, and then that tension pneumothorax. Anything that causes impaired filling because of some type of obstruction. And then we have cardiogenic shock. So this is a decreased force of ventricular contraction leading to inadequate intravascular volume and ultimately tissue hypoxia. So this is your heart attack, your myocardial infarction, and your cardiac arrhythmias. So hypovolemic shock, also called hemorrhagic shock, is the most common. This is where our volume of extracellular fluid is significantly diminished, and it is due to lost or reduced blood or plasma. This type of shock is going to cause a reduction in our circulating volume, causes significant bleeding. So during surgery, any kind of trauma, delivery of a baby, significant fluid loss associated with burns, large draining wounds, reduced fluid intake, so dehydration, prolonged GI suctioning, so our NG tubes, disorders in which fluid losses exceed our fluid intake, and then such as diabetes insipidus. Losses of 30 to 40% usually require blood and fluid replacement. So you're getting those packed red blood cells and you're getting some type of IV fluid. Any loss greater than 40% is going to be considered life-threatening. So this is just a clinical picture of what you would see with a patient who has hypovolemic shock. You're going to see that altered mental status. They're going to be restless. They're going to be anxious. They might even be disoriented as it starts to progress because you don't have that good circulating volume, so you don't have a lot of oxygen getting to the brain. They're going to be tachycardic. They're going to have tachycardia because there's not enough blood coming out of the heart. So the heart thinks, oh my gosh, there's not enough oxygen. There's not enough blood. I have to pump harder. I have to make more. Dyspnea due to the loss of blood loss and the lack of red blood cells carrying that oxygen. Patients are going to be cool and clammy, right? Because the body's going to be shunting blood to other areas, the brain and the heart. Decreased urinary output because we're not going to have good blood flow to our kidneys, or they're not going to be perfused properly. So we're going to do fluid replacement, and then we're going to treat those signs and symptoms that we see. So we're going to give oxygen. They might need a blood transfusion, monitor those vital signs. So distributive shock. This is the amount of fluid in the circulatory system is not reduced. The fluid circulation does not permit effective tissue perfusion. So this is not a reduction of our circulatory fluid. The circulatory fluid is still fine, it's still adequate, but the fluid circulation is not appropriately perfusing our tissues. So we have vasodilation, which is the prominent characteristic of distributed shock. You're going to see huge vasodilation throughout the body. It's going to cause an increase in the space in our vascular beds. Our central blood flow is going to be Our central blood flow is going to be reduced because of the peripheral vasodilation. So we have three types of distributive shock. We can have neurogenic, septic, and anaphylactic. So neurogenic shock, this is the rarest type of shock. We don't see this a lot. This is going to be a result of an injury that affects our vasomotor center in the brain, or to the peripheral nerves that extend from our spinal cord that go to our blood vessels. So these are patients that have had spinal cord injuries or head injuries. So just some examples I have listed here: overdoses of opioids, tranquilizers, or general anesthetics can cause neurogenic shock. So it might be something that we do in the operative setting if we give too many anesthetic medications. It's going to cause the tone of the sympathetic nervous system to be impaired, which is going to result in that arterial vascular resistance, which is going to cause vasodilation and then hypotension. Our blood is going to stay in the periphery. The heart will not be able to fill adequately because there's so much space in there now. We don't have enough pressure to get it back. Our cardiac output is going to be reduced. Our tissue perfusion is going to become compromised. We're not going to have the appropriate amount of oxygen going to our cells. It's going to cause an increase in lactic acid as a result. So that's neurogenic shock. You guys can read this. This is just a little slide that shows you all the signs and symptoms and explains it a little bit better. So now we're going to talk about septic shock. So this is also known as toxic shock. You'll see those terms used interchangeably in the medical setting. This is very common. You see this a lot in the hospital, and it has the highest mortality rate. It is associated with overwhelming bacterial infections that move into the blood. So septic shock is always preceded by a systemic inflammatory response syndrome, what we call SIRS, which is an inflammatory state without a proven source of infection. So it looks like something's going on, but we can't actually say this is the bacteria that's causing the problem. SEERS will progress to sepsis when the symptoms of SEERS are present and an infection is proven. So it's not going to be sepsis until you have the symptoms and we can actually send off blood cultures or do something and actually get a lab back that says this is the infectious bacteria that we found. So I want you guys to know that those two have to go together. Severe sepsis is pre-septic shock. That develops when sepsis is combined with organ hypoperfusion. So our organs are not being perfused. When it's accompanied by hypotension, so we know hypotension is low blood pressure is low circulatory volume. We're going to see marked deterioration to the point of multiple organ dysfunction syndrome. This is a indicative sign that patients are close to death. Sometimes this is not reversible. Septic shock occurs commonly in patients that have gram-negative drug-resistant Staph aureus or gram-negative bacteremia, so E. coli and certain species of Pseudomonas. So we see this very commonly in patients who have UTIs. It is very common for that older adult to come in and the family member will be like, I don't know what happened to my grandmother. She just all of a sudden got confused. She was perfectly fine. Whenever you see that scenario, you should always think UTI. That's how UTIs present with older adults. And they get septic very, very quickly, which means that bacteria has been growing and manifesting, and then it goes into their bloodstream. We see it commonly with that. We see it with central lines. So our cancer patients that have ports and central lines, it's very common if we're not doing sterile technique. When we handle these lines, they can get an infection in their line. They can move into their bloodstream. Those are two of the most common patients that we see it in. It's always possible with like the flu and pneumonia, if things progress, that you can also become septic from that. So usually with septic shock, it's bacteria that triggers this immune response. We have these vasoactive chemicals that we call cytokines. They're released in the blood and they dilate the blood vessels and cause an increase in our capillary permeability. When we see that increase in permeability, it's going to cause vascular fluid shift to the interstitium. We're going to see elevated leukocyte counts and initially a fever accompanied by, they're going to have warm, flushed skin, and then a very rapid bounding pulse. Those are those compensatory mechanisms. As sepsis further progresses, and they become hypoxic, the patient is going to be cold, they're going to be pale, they're going to have mottled skin, and they're going to have those hypotensive systems. So the compensatory mechanisms are failing, the patient is progressing, and these are the symptoms that we see. That's a bad sign when you see those symptoms progress. So this is the progression of SERS to septic shock, excuse me. So with SERS, you're going to see a fever, right, greater than 38 degrees or a temperature less than 36. You're going to have heart rate greater than 90, respiratory rate greater than 20. You did an APG, that PaCO2 is going to be less than 32. We might see white blood cell counts greater than 12,000, indicative of an infection, or less than 4,000. So we would see less than 4,000 in our patients who are neutropenic, so our cancer patients that don't have any white blood cell counts at all. They're at a very high risk of getting some type of a bacterial infection that can kill them. So they could have all these symptoms, but they could be neutropenic. They don't have any white blood cells. So that is going to be your SERS. When it moves into sepsis is when you have all of the components of SERS, so that high temperature, the high heart rate, the high respirations, plus now we have a concrete evidence of an infection. So we sent off blood cultures that came back that they have gram-positive E. coli in their, in their urine, whatever the case may be. So we have all the symptoms of all the objective data of SERS, but we also have a clinical finding of an infection. So now we have sepsis. When it progresses to severe sepsis is when you have sepsis which is the SIRS plus the infection, and now we have end organ damage. So our liver's failing, our kidneys failing, and then we have septic shock when we have severe sepsis. So we know what sepsis is, which is all the components of SIRS plus an infection, plus we have end organ damage, and now we have hypotension because those compensatory mechanisms are failing. So you guys need to know this process, and you need to know what's included in each. You're going to see that on your exam. And then the last one of distributive shock is anaphylactic shock. So this is a severe allergic reaction after an exposure to a substance to which a person is extremely sensitive. So common allergic reactions we see is bee venom, latex, fish, nuts, so peanut butters, penicillins. Those are some common allergic reactions. Our body's immune response to an allergic substance that it meets causes the mast cells that are located in our connective tissues, our bronchi, our GI tract. They're going to start to release histamines and other chemicals. When the histamine and these other chemicals are released, it's going to produce vasodilation. We know what happens with vasodilation. Everything dilates. We get more blood flow through, our pressure is going to drop. It's going to cause increased capillary permeability. But these patients are also going to have swelling of the airway, of their subcutaneous tissues. They might have hives. They're going to have that hypotension, or they could even have an itchy rash. This is just a little slide for you guys to read when you're studying about anaphylactic reactions. This is just an overview of distributive shock. You guys can read this. All right, so obstructive shock. So obstructive shock is the interference with the circulation of blood in and out of the heart. So this is anything that compromises the volume of blood that enters and leaves the heart going to the lungs and to the tissues. So causes of obstructive shock, this would be any condition that's going to cause our thoracic cavity to fill with fluid, air, or tissue. We see obstructive shock in patients that have cardiac tamponade. We talked about that. That's that increased in fluid or blood in that pericardial sac that puts pressure on the heart so it can't beat. We have the tension pneumothorax, which is where that air accumulates between the layers of the pleura, also putting pressure on the heart. And then if we have patients that have an enlarged liver or ascites, so these are patients that have liver damage. It can be patients that suffer from alcoholism that have cirrhosis of the liver. The abdominal tissue and the fluid or air is going to crowd that diaphragm, and it's going to reduce the size of the thorax, and it's going to put pressure on the heart. And this is another slide that you guys can read about obstructive shock. So cardiogenic shock. So this is when the contraction of our heart is going to be ineffective. Our cardiac output is going to be reduced. So that volume of blood coming out of that left ventricle per minute, right, our ejection fracture is going to be reduced. What causes cardiogenic shock? A myocardial infarction, so a heart attack with subsequent heart failure. And this is the process of cardiogenic shock. You guys can read over that. So when we talk about shock, we always have 3 stages. So we have compensation, decompensation, and irreversible. With irreversible, we're always going to see multi-system failure. We're talking about your kidneys, your heart, your lungs, your liver, and your brain. That's a bad sign. Usually patients that see irreversible shock, they are pretty close to death and they usually don't survive. So in the compensation stage, this is exactly what you think it is. It's our body doing things to compensate for what it's experiencing. So this is the first stage of shock. Physiologic mechanisms in our body are going to attempt to stabilize the situation. If those mechanisms are unsuccessful, then we know our homeostatic stability is going to be achieved. Everything's going to go back to normal. If natural or medical means can reverse the shock, the chances of uncomplicated recovery are greatly improved. So we always want to be able to have our bodies compensate on their own. And if it can't, we can help it along, and then we want to see our patients make a recovery. We want to reverse the changes. As shock progresses, positive outcomes are going to be less predictable. So we want to be able to recognize shock in its first stage, because that's the stage where the likelihood of improving things is the greatest. So what are our compensatory mechanisms for shock? Well, we have the release of catecholamines, we have the activation of the renin-angiotensin-aldosterone system, and the production of antidiuretic and corticosteroids. So the release of catecholamines, this is when whatever's happening in the body is going to stimulate our sympathetic nervous system. Once that system is stimulated, it's going to cause our heart rate to increase. That increase in heart rate is going to cause our myocardial contractility to be stronger. So we're going to have more blood put out with each contraction of the heart. Every time that happens, it's going to increase our circulatory volume, which is going to increase that venous return, and it's going to cause bronchial dilation. The activation of that renin-angiotensin aldosterone system, you know, this is the system that we use to restore our blood pressure, and it's going to increase our blood volume. And then the production of antidiuretic and corticosteroids. So this is our ADH and our ACTH, which help control our sodium and our water balance. And I did put some stuff down here in the notes for you guys that talks exactly how that whole compensation system works. So you guys should read that. It breaks everything down. So the next stage of shock is decompensation. So this is when we see failure of that compensatory mechanism. So we're going to see cellular hypoxia, coagulation defects, and we're going to start to see cardiovascular changes. So with cellular hypoxia, our oxygen levels that reach the cells is going to be decreased. Hypoxic cells are then going to be forced to switch from anaerobic metabolism to anaerobic metabolism. And if you remember back to biology, anaerobic metabolism is less efficient. It's going to cause our lactic acid to increase, and it's going to cause our patient to have metabolic acidosis. We're going to start seeing coagulation defects. Those cells are going to become damaged. Once they become damaged, they're going to secrete, signal an inflammatory response, which is going to go out to the area of injury. It's going to cause a release of platelets. Those platelets are going to become sticky. They're going to start accumulating and building up in our blood vessels. The client is then going to have the formation of blood clots, which is going to further compromise the ability of those red blood cells to circulate through the body and deliver all that oxygen-rich blood. And then our cells and organ death are going to be potentiated because nothing is getting perfused. So then nothing's getting perfused. We're going to see those cardiovascular changes. The myocardial cells are not going to be able to maintain a sufficient heart rate, and they're not going to have that good contraction to efficiently circulate that blood through the body. Once our circulation, our cardiac output decreases, then our brain cells can no longer sustain the stimulus to cause vasoconstriction because we're not getting oxygen or blood to the brain. Once that vasoconstriction stops, we're going to see our blood vessels dilate. Our blood is going to start pooling in the periphery, or it's going to leak into the interstitium. We're going to have a decreased cardiac output. Our blood pressure is going to fall. So clinical signs that we're going to see in our patients, we're going to have bradycardia, right? Our blood pressure is falling, our cardiac output is decreasing, which means our heart rate is decreasing. So bradycardia. These are later signs. Hypotension, blood pressure is falling. Confusion, our brain's not being oxygenated, so the person is not going to be alert and oriented. They're going to be extremely lethargic. They might even be unconscious or in a coma at this point. We're going to have decreased urine output. We have no circulating volume, so our kidneys cannot get perfused. Vasodilation, right? No vasoconstriction. So instead of warm and pink, we're going to be cold. We're going to have pale skin. There's no blood flow there, and reduced peristalsis. Constipation, no urine output. aggressive interventions are going to be necessary to prevent irreversible stages of shock and to ensure that the fact that our client will be able to survive. And then if they're not able to help the patient through that decompensation stage, then we're going to move into the irreversible stage. So this is where we see significant cell and organ damage. This is where the client reached what they call a point of no return despite all of the treatment efforts. The client no longer responds to any type of medical interventions. We're having multiple system failure, brain, heart, lungs, kidneys, none of them are going to function, and then death is imminent. So what does our assessment look like for the nurse? So we are going to monitor for compromised blood flow or circulation. So how are we going to monitor for compromised blood flow? What type of assessments can you guys do that can monitor to see if they have good blood flow and good circulation? Angie or Ange, what can we do to monitor?
You can check the pulses.
I can't see you. Is your camera on?
Yes, it is. I'm sorry. Can you see me now?
No. Is it Ange that's talking? No, I called on Ange. Angie? Is it
I first said Angie. I'm sorry.
no? Is it Ange or Anjay? How do you say her name? I don't think she's there. All right, how about Joel? What do you think? How can we monitor for compromised blood flow in our patients? What kind of things can we look at?
Use a pulse ox.
Yes. Yeah, we can use a pulse ox. What else can we use?
Check pulse.
Check for pulses. Yep,
See if the extremities are warm.
exactly. Are they warm? Are they cool? Do they have any swelling? Checking that apical pulse, checking their mental status. So vital signs, changes in mentation, skin, urine output. These are all important.
And I'm sorry, it's Joelle.
Joelle, I'm sorry.
It's okay.
Something else that some hospitals use is the Apache scoring system. So Apache stands for Acute Physiology, Age, and Chronic Health Evaluation. So this is a scoring system that reflects the severity of your patient's status, and it's going to predict how long they will have to stay in a critical care setting. Basically, the higher score is indicative of a higher risk of death. I'm not going to go into detail about this, but you guys should know what it does and what it looks at, and what it determines. So we can look at arterial blood pressure. So this is, we're going to see a decrease. It could just be systolic or diastolic at first, and then eventually it's going to be both. So both numbers are going to decrease due to that decrease in our cardiac output. We're going to see hypotension. It could be very rapid, it could be sudden, or it could be very slow, depending on what's going on with the patient. Could be gradual. So your book says that a systolic blood pressure of 90 to 100 indicates impending shock, whereas 80 or lower indicates shock. The thing about this is that you have to have a baseline of your patient's blood pressure. My blood pressure is always in the 90s over 60s. I'm not in shock. So you need to know what your baseline is. So if you go to your patient, maybe he's been here for a couple of days and it's your first day having him, and you go in and you check his blood pressure in the morning because you're going to give some medications and it's really low. Then you need to go through that chart. You can ask the patient, what does your blood pressure normally run? They might not be able to tell you that. Go through the charts, look and see what it was when they came in, look at how it's been trending since they've been there. That will give you some idea of, maybe 90s over 60s isn't normal, but maybe that's where this patient lives and that's where he's been. So this wouldn't be an alarming finding. If your patient is normally 140s over 80s and then all of a sudden he's 90s over 60s, well, that could also indicate that something's going on. But then you also look at it in comparison with your other symptoms. You just don't look at that one thing. You're going to look and see, do they have a fever? What's their respiratory system like? Are their respirations increased? Are they tachycardic? So you want to look at that whole picture. So just keep that in mind. We can do direct blood pressure monitoring. So in the ICU setting, in the SICU setting, which is the surgical ICU, we can do arterial monitoring where they put it in an arterial line. So it's very, very accurate. It's checked every 6 or 7 minutes. And then you could do an oscillatory method. So you should always do a manual if you have a sudden change in blood pressure, because when you call that doctor and you say, hey, I'm taking care of Mrs. Jones today, her blood pressure dropped, she's 90/60. He's going to say, did you do a manual? Because we want to know for sure that's just our, maybe we don't have faulty equipment. So always make sure you do a manual. We're going to monitor their pulse pressure. So remember your pulse pressure. We talked about this in fundamentals. This is the numeric difference between your systolic and your diastolic blood pressure. If that number is decreased, we say that the pulse pressure is narrowed. So these are the terms we're going to hear in the clinical setting. And then we're going to look at their pulse. So what is the rate of their pulse? Remember in the very beginning when we have those compensatory mechanisms working, it's going to be tachycardia. Then as things start to compensate and things are failing, it's going to move into bradycardia. What is their volume like? Is it weak? Is it thready? Is it bounding? And then what is their heart rhythm? Eventually, as things change, we're going to get to an irregular rhythm to maybe no rhythm at all. All right. Respiration. So we know that with shock, the tissues are going to be receiving less oxygen. Less oxygen is going to cause our respirations to increase because we need to obtain more oxygen. Their respirations can be shallow. The client might be grunting. They might be using their accessory muscles. In the early stages, the client is going to be what we call air hungry. They're just going to feel short of breath. As death gets closer, as decompensation starts to occur, the respiratory rate is going to decrease. So at first, it's going to be a very high rapid, their respirations might be 28, 34, even upwards of 40. And then as death is near, then they're going to be a lot lower. We're going to want to look at their temperature. So heat regulating mechanisms are going to be depressed in shock. Because that happens, we're going to have diaphoresis, which is going to increase our heat loss. We're going to have subnormal body temperature, except with septic shock. With septic shock, you're going to have a fever. We're going to look at mentation. So we know that patients that have inadequate oxygen, we're going to have impaired blood flow to the brain. We're going to have that altered cerebral function. The patient is going to start to be anxious. They're going to be apprehensive. They're going to be restless, agitated, and then it's going to move into confusion as decompensation occurs and things get worse. They're going to become liftless, stuporous, and there's going to be a loss of consciousness. When we look at their skin, it's going to be cold and clammy, except for the early stages of septic and neurogenic shock. In the early stages, they're going to be warm and flushed. They're going to have fevers. Peripheral blood vessels are going to constrict, which is going to send more blood from the skin to more vital organs, right? The body knows where it needs to be. We need to perfuse the kidneys, we need to perfuse the heart, and we need to perfuse the brain. That's part of your compensatory system. So it's going to shunt that blood away from the skin. The skin's going to become pale, and the skin may appear mottled. So this is what I'm talking about when I tell you guys that you need to recognize the symptoms of compensation. That is, when you saw that in your patient, you would know that there are compensatory systems working in your patient to try and fix the problem. You're going to see capillary filling longer than 3 seconds. We know that normal is less than 3 seconds. So these patients, it's going to be longer. We're going to see cyanosis, especially in the nail beds, the lips, and earlobes, which are going to be indicative of oxygen deficiency. A lack of cyanosis does not prove the absence of hypoxia. Cyanosis is always going to be the last sign that we see with shock. So it's a later sign. It does not mean that lack of it, that they don't have hypoxia. Hypoxia is a very early sign. You guys need to know that. Urine output, we're going to have reduced cardiac output. We know when we have reduced cardiac output, we have decreased circulating volume. We're not going to have great blood flow to the kidneys. That's going to cause our urine output to diminish. Vasoconstriction is a physiologic response to shock, is also going to contribute to markedly reduced renal blood flow. The rate of urine formation is also an indicator of status and renal damage. That's why I always say every patient, regardless of what order your doctor puts in, you should always have your patient on strict I's and O's. These can be early indicators of decompensation in your patient. You should be monitoring them every 4 hours. Diminished at first, but then, so with shock, sometimes they will be diminished, but then as we start to reverse things and the patient starts to improve, then that's going to return. Your patient's going to start to have good urine output again. If things continue to progress or we have renal damage from whatever was going on, then we're going to start to see oliguria. I want you guys to remember with your African-American patients, you might not always be able to see cyanosis in them because of the color of the skin. So you guys have to remember that you have to look other areas. So you want to check the conjunctiva and their oral mucosa. Those are going to be your indicators. I don't know if you guys remember that from funds or not. So we're going to do, for diagnostic findings, we're going to be doing ABGs, right? Looking at O2, carbon dioxide, and your PaO2. We're going to check central venous pressure. So this is pressure that's located in our right atrium. If your patient is having hypovolemic shock, it's going to be lower than normal. And if they have cardiogenic shock, it's going to be above normal. So we would expect in hypovolemic shock for it to be lower than normal because that circulatory volume is not getting back there. You're not going to have that high blood pressure, that high pressure. Pulmonary artery pressure, this indicates the status of our right ventricular pressure. The pressure on the left side of the heart is going to be more pertinent than the right. So to assess our left ventricular function, we look at pulmonary artery pressure, our PAP, so it should be 20 to 30 systolic and 8 to 12 diastolic. We also look at our pulmonary capillary wedge pressure, lower than normal with shock. We're going to see because of that low volume in the arterial system. So 4 to 12 is going to be normal. So what are we going to do for our patients? How are we going to medically manage them? The patient is going to be ordered fluids. So we are going to give crystalloid solutions, colloid solutions. This could be your albumin, and sometimes they're going to require packed red blood cells. So we're going to be giving Ringer's lactate. We're going to be giving normal saline. Those are great for our hypovolemic patients. Drug therapy, we're going to give vasopressors, which raise our blood pressure by constricting those peripheral blood vessels. So we can give norepinephrine, which is also called Levophed, and we can give vasopressin. We can give inotropic agents, which improve the force of the heart contraction. So your digoxin, which is lanoloxin, which you always monitor for toxicity. We're going to give dobutamine or Dobutrex or Milroney or Primacor. Your vasoconstrictors, these are going to increase myocardial contraction and divert blood flow to those important internal organs. So we can give dopamine, which is also inotropin, and we can give epinephrine or adrenaline. And then sometimes we need to do mechanical management. So these patients are going to be in the ICU. They can do what's called an intra-aortic balloon pump, a ventricular assist device, or a pneumatic anti-shock garment. You can read more about these in your book. So what is the prognosis of shock? So like we said earlier, when treated adequately, when we recognize those signs early, the client usually recovers. Recovery can be tenuous, secondary to those other complications that we're seeing, which are almost always going to be a result of that tissue hypoxia that we see and organ ischemia caused by that reduced oxygenation. So early treatment is always better. Life-threatening complications, we talked about them. That's going to be your kidney failure, neurologic deficits, bleeding disorders. So you can have something which is called disseminated intravascular coagulation, where you just start throwing clots everywhere throughout your entire body. That usually does not have a good outcome. Acute respiratory distress syndrome, sepsis, we know can lead to multiple organ dysfunction. So nursing process, what does that look like for the nurse? So you are going to assess for those early signs of shock, monitoring your eyes and O's, monitoring your vital signs, heart rate, temperature, pulses, doing those good physical assessments. Report any abnormal findings to the physician immediately. Check vital signs on initial contact and frequently thereafter. So if patients in the hospital, whenever they come to your floor, they're going to get a set of vitals. And then for the first 24 hours, you normally monitor them every 4 hours. And then after the first 24 hours, or you go to monitor them every 8 hours, or unless there's a reason why you feel like you need to monitor them more frequently. You're going to observe their skin color. You're going to monitor their temperature. You're going to assess the rate and the quality of those radial and your peripheral pulses. Monitor that urine output. Determine respiratory rate and effort, because you want to detect any evidence of dyspnea or any type of airway obstruction. And then you want to inspect for bleeding or other causes that may explain the developing symptoms of shock. So looking to see if there's blood in the urine, looking to see if they just had a surgery, where's that surgical incision? Is there any blood coming from there? Could it be internal bleeding? Do they have a GI bleed? Maybe we're going to look at their stool. We're going to send off a stool sample. Really look at those other causes. We're going to determine the level of consciousness and our orientation of our patients on a regular basis so we can detect those changes early. For patients with suspected cardiogenic shock, we're going to auscultate the chest for any abnormal lung and heart sounds. We're going to be checking our lab test results for low red blood cells, hematocrit, and hemoglobin levels, which we know could correlate with hypovolemic shock. We're going to look for elevated white blood counts that could support septic shock, because remember, septic is from bacteria. We're going to obtain those ABGs, determine those findings, look for evidence of hypoxemia, and metabolic acidosis. We're going to look at those serum lactate levels, which could suggest lactic acidosis, which could be precipitated by sepsis and septic shock. We're going to be monitoring their oxygen levels, and then we want to monitor those coagulation tests. So we want to look at their platelet counts. Do they even have enough platelets? Maybe they have low platelet counts. Is their count really high? Are they at risk for developing a blood clot? We want to look at their PT, which is their prothrombin time, their INR, which is the International Normalized Ratio. We just call that the INR. We never say that whole thing out. If we're talking about prothrombin time, we just say the PTT or the PT INR, and then their partial thromboplastin time is we just say that as PTT. So you'll hear that interchangeably in the clinical setting. Can you get a PT INR? Can you get a PTT and an INR? That's how we say it. So then our nursing diagnoses, these are what we're going to see. So decreased cardiac output related to whatever's happening. So it could be blood loss, impaired fluid distribution, impaired circulation, the heart's inability to contract, or a massive vasodilation. We're going to have ineffective peripheral tissue perfusion because of that reduced cardiac output, which is going to be secondary to heart failure, blood loss, abnormal fluid distribution, vasodilation. And then we could also have bradycardia secondary to some type of neurologic trauma or adverse effects from central nervous system depressants. Impaired gas exchange related to the edema of the airway, secondary to severe allergic reaction, leading to anaphylactic shock. Hypothermia, which is going to be related to hemorrhage. Hyperthermia related to altered temperature, which would be secondary to sepsis. And then what is our evaluation of our expected outcomes? Well, we want our patients' vital signs to be stable. Everything should be within normal limits or close to that, or at least trending in the right direction. Tissue perfusion is going to be satisfactory. How are we going to know that our tissue perfusion is satisfactory? We're going to have good urine output, right? We know our kidneys are being perfused. We're going to have good pink color. We're going to have good palpable pulses. Adequate urine output, warm, dry skin, capillary refill is imminent, and then we want our ABGs to be within normal range, or we're going to start to see that compensation so that we know that our system is trying to fix things. All right, that is the end. So we actually finished up a little early. So if you have any questions, you can ask me now.